So how do we think about 189 and 150 in terms of in my mind, when you have on 189 we have the control arm with a median survival of 11 months. And in 150, we have the control arm with a median survival of 14 months.
Keep in mind that those are non-squam
Right,
Bev-eligible
so
patients.
that's my point, is that not everyone should get Bev because
Right.
of the contraindications. And so it's hard for me, I think this is a situation where it's very difficult to make cross-trial comparisons.
It's very difficult.
If not impossible.
But it's different
True.
populations.
It's
and I
different
think that you have
populations,
to
and
be
I think this
careful
is the one place where cross-trial comparisons really are not going to be helpful.
Right.
Because of,
Thank you, Karen.
I mean, we'll be doing a lot of
Yeah.
cross-trial comparisons,
Yeah.
but because we think that the patient populations are similar, like 042 and 189, but this setting, they're not.
Yeah. So Ben,
I think it's important that this is really the only trial I'm aware of, certainly that's been reported, that's included EGFR and ALK. They were explicitly excluded from 024. They were excluded from 189. They were excluded from our 021G pilot randomized phase 2. I believe they were excluded from 042. From all the other, certainly from the Pembro trials. So, the final common pathway for patients with oncogenic drivers remains chemotherapy. Eventually, the TKIs will stop working. And this regimen then becomes, I would say, the standard of comparison in that population.
Right. I think the fear, though, is what we've been talking about, is that the sequencing is not going to be done, all right? That the sequencing is not going to be done up front like it should be, and that these patients will just be placed on these, the triplet combination. And I really want to emphasize that again, the standard of care is to do the testing and then make the treatment decision. Whereas, again, because you may, again, as you pointed out, Ben, may not be doing testing in anybody, people may not continue to do testing. So I think it's really important that people remember the workflow.
And that TKIs come first for
Right.
these patients.
TKIs come first. It's a different
yeah.
set of patients. You're talking
It becomes a bit of a
upfront
dilemma.
versus pre-treated patients with TKIs. So the workflow process is a little different.
The dilemma comes up sometimes, though, that PD-L1 results come back first, even while you're waiting for EGFR and ALK. And I'm sure all of us have dealt with this situation where PD-L1 is astoundingly positive, it's 70%, but they also happen to be EGFR mutant positive ALK. The oncogenic driver, I agree, trumps chemotherapy or chemo-IO combos in that population.
But you don't want to put them on, if they're 100%, I've had a patient who's had 100% PD-L1 and also had an EGFR. She did not do well on immunotherapy.
And we'll learn this,
and we've seen this time and again. Yeah. So you can't, even if you get that result back, you have to wait for those other results.
We're going to learn very soon at this meeting about the role of single-agent pembrolizumab for an EGFR positive patient with a PD-L1 greater than 50%. It's small numbers, 8 patients, prospective study, response rate 0.
Yeah.
Right.
So I say to my referring doctors that PD-L1 only should be considered after you know the results of EGFR, ALK, ROS1, and BRAF. That's the NCCN recommendation. Those drivers trump PD-L1. And I think that, as Ben just pointed out, the real effectiveness of immunotherapy in those oncogenic driver subsets is less than what you would expect. Yeah.